I'm really excited to have you joining us tonight for our April speaker series. We've got a great topic and a great speaker. I'm sure this is a subject that many of us will be going back to re-listen because this discussion around genetics, genomics, and the technology that's coming out can feel like a lot. So know that this will be available in our video library. So I'll give it another minute before we get started, but I'm really excited to have everyone here with you. As more of our guests are joining, let me introduce myself. My name is Erin Pellegrin. I am our Senior Director of Culinary Nutrition and Education. I'm usually joined by Sue Weldon to lead these education segments each month, but tonight you just have me, so I'm excited to be here with you. Feel free to hop into the chat and share where you're tuning in from. Feel free to use that chat as well as Dr. Audie moves through his slides. Of course, we'll have some time for questions at the end, but feel free to comment if you've used this particular test, or again, share any of those questions. Couple housekeeping tools. I just want to remind everyone to mute yourself so there's no distractions. If you need assistance with muting, let me know. I'm happy to help you with that. At the end, if you have questions, you're welcome to raise your hand or come off of mute, or again, use that chat button. Tonight, we are diving into the importance of understanding genetic testing in treatment decisions, and we are joined by a true expert in this space. So we'll learn the difference between genetics and genomics this evening, and how genomic testing can be a useful tool as part of your overall treatment decision making. Now, I do want to give one disclaimer. So Dr. Audie will be discussing particular tests, MammaPrint and Blueprint genomic testing, which are proprietary products of Agendia. Unite for Her has no affiliation with, have not received financial support from, and do not endorse any of the products referenced herein. Any mention of specific products or brands is for informational purposes only and does not constitute an endorsement or recommendation. I also want to share my screen because I want to give a big thanks to our education sponsors this evening. So we could not continue to bring you segments and speakers like we have this evening without our amazing education sponsors. So our virtual education events this evening are presented through UFH Connect by West, Merck, Lilly, and Gilead Sciences, with additional support from our gold sponsors, Pfizer, GSK, and Daiichi Sankyo, and our supporting sponsors, AbbVie, Agendia, and Tercera Therapeutics. So grateful for ongoing support, continuing our education segments. And with that being said, let me give a little teaser of what we have coming up throughout the rest of the month of April. So next week, we have an Ask the Experts, and it is our partnership focus. So we love highlighting the incredible work that our partners in the nonprofit space are doing to serve the cancer community. So we have an Ask the Experts happening on April 17th, 1 p.m. Eastern Time. We will be streaming live to the Unite for Her Facebook page, and we will be connecting with 305 Pink Pack and their founder, Rosemary Carrera. She is truly a force to be reckoned with. 305 Pink Pack is a nonprofit that provides direct support services to women in cancer treatment in South Florida at no personal cost to themselves. So we'll be joined by their founder, like I said, to answer all the questions about their organization, the services they provide, and if you're in that general area, how you can get connected and receive support. And then we have our virtual hangout. So this was a reschedule from earlier this spring, April 22nd. That is a Tuesday, 4 p.m. Eastern Time. We're going to have a little makeup session. So we're having a makeup how-to with a true pro, senior cosmetic and medical tattooist, Mandy Soller from the Soller Institute. She will be joining us and teaching us expert tips and techniques to enhance natural beauty, boost confidence, and create a look that is perfect for all of us. So as we age and how we notice some of those changes, perhaps as a result of treatment or just as we're all getting older, our tips and techniques have to evolve as well. So Mandy will be teaching all of us. And all of our education segments, including this evening, will be available in our video library. You can visit at uniteforher.org/UFH Connect. Wonderful. All right. I see a lot of guests popping in from all over the country. So I am very excited. Atlanta, Southampton, Lancaster County. Wonderful. Indiana. Love this. So welcome to our speaker series. Let me begin by introducing our incredible speaker this evening. So Dr. William Audie, Chief Medical Officer at Agendia, is a medical oncologist specializing in breast cancer. With nearly 30 years of experience as a clinician and clinical researcher at the Cedars-Sinai Cancer Center in Los Angeles. Prior to joining Agendia, and in addition to his clinical practice, he served as the former director of the Cedars-Sinai Cancer Center and medical director of the Wasserman Breast Cancer Risk Reduction Program. He has been principal investigator on a wide variety of national and international clinical and translational trials, and has authored numerous publications in the field of breast cancer, cancer genomics, and targeted cancer therapy. So please join me as I welcome our incredible speaker this evening, Dr. William Audie. Dr. Audie, thank you so much for being here. We are so excited.
Well, thank you so much, Erin, and thank you all for joining us today. This is really an honor for me to be able to speak with you. And let me share my slides and press on with the presentation. Well, again, I'm really honored to be able to speak with you all this afternoon or evening about this topic, taking control of your breast cancer journey and understanding specifically the importance of genomic information in making treatment decisions. Now, you heard a lot about my background in breast cancer just now, so I won't belabor that, but I do like to show where I used to work. I used to work at the Cedars-Sinai Cancer Center right there, and also taught at UCLA as well. So after over 30 years, really, of working in the clinic, doing clinical research, caring for women with breast cancer, I chose to make a change to work with Agendia full time. I do have a background in genetics and did a lot of genomics research, and I felt that it was high time that genomic information became standard in the decision making of every physician managing people with breast cancer, and of course, every woman and man who are dealing with that diagnosis. And that's really what I want to talk to you about today. Today, I'd like to talk about the difference between genetics versus genomics, just to set the stage for talking about why genomic information is really so valuable nowadays in breast cancer, and I think will continue to be for quite some time. And then specifically how you can use genomics today to inform many treatment decisions, particularly, of course, in newly diagnosed women with breast cancer. And also talk a little bit at the end about what the future holds for genomics in breast cancer care. So to begin with, what do we mean when we refer to genetic testing versus genomic testing? I certainly wouldn't say that there's a specific definition, but I can comment on the way these terms are used commonly nowadays. So when we talk about genetics in this setting, in breast cancer, for example, we're really talking about the genes in the individual person and all the cells within you. And these are the genes that have been inherited from your parents. And again, that are, for the most part, normal genes that are carried in every cell. We're particularly interested, of course, in specific genes which affect the risk of breast cancer and other cancers, and that's what we do genetic testing for. And to do that, we do the testing on normal cells, not cancer cells. We take cells from the blood, or sometimes scraping cells from the side of the mouth to get the genetic material, the DNA, that tells us something about the genes we're looking for. And the best example of genetic testing in breast cancer is to look for the BRCA gene, which can be mutated and inherited over many generations, and of course increases a person's risk of developing breast cancer sometime in their life. Now, that's quite different from genomics, because in genomics, we're looking at the genes in the cancer itself that are likely to be quite different and abnormal when compared to all the other genes in the normal cells. And when we look at genomics, we're not really looking so much for abnormal genes or mutations. We're actually looking for how the genes are working together, which genes are turned on or turned off, because that's affecting many aspects of cancer. It affects how the cancer is growing. It also affects how the cancer might respond to therapy. So getting the genomic information is critical for making the best decisions, particularly at the time of initial diagnosis. And of course, the testing is done directly on a sample of the cancer tissue. We need very little to get enough of the genomic material to get our answers. And of course, what I'll be talking about is a genomic assay known as a MammaPrint, which is made up of 70 genes that we look at to determine which of those are on or off. Now, before I talk more specifically about MammaPrint and one of the other tests that we have called Blueprint, which looks at another aspect of genomic information, let me just step back for a moment and talk about how genomic information in general can be helpful in breast cancer. I would say that what it gives us is a better understanding of breast cancer than what we now have with clinical and pathology features. So when we define a breast cancer and try to understand how best to treat it, of course, we start with the clinical stage, which is how large is the tumor? Did it move into the lymph nodes or not? And then we look at it under the microscope, of course, with a biopsy before surgery and then after surgery. And that gives us the pathology, what these cells look like under the microscope, shown here. And so one way we define it, of course, is to put a label on this cancer. And you've probably heard the terms ductal, invasive ductal breast cancer or lobular breast cancer. There are other types, of course, but these are the most common. And then what pathologists routinely do is to stain the cells to see what's on their surface. And that's how we learn whether a cancer has estrogen receptors, hormone receptors, or the other important receptor, HER2, HER2, or in the cases where there are neither of these receptors, so-called triple negative breast cancer. Those are the major categories that you know, I think, that are defined by clinical and pathology analysis. But what's missing here is that we don't know from all that information what's actually going on inside the breast cancer cells. That's where genomics comes in and gives us an extra layer of critical information. When we obtain genomic information in breast cancer, we're actually asking, as I said earlier, which genes are active or inactive. That's referred to as gene expression. And it's quite a simple and straightforward process. It's shown here. We take a sample of the cancer, either from the original biopsy that made the diagnosis or from the surgical sample when the cancer is fully removed. We extract the genomic material. In this case, we look at RNA rather than DNA. And we go through several steps in our lab, which is based in Southern California, and measure the expression of the genes, which are on, which are off. In this particular case, we're looking at 150 different genes that are important in breast cancer that make up the two tests I'll be talking about. The MammaPrint test, which tells us about the risk of recurrence of that cancer and whether or not it needs chemotherapy. And then the Blueprint test, which tells us the type of breast cancer we're dealing with beyond just the surface receptors, and helps us design the best treatment to eradicate that cancer. Overall, this is providing insights that go beyond traditional pathology. We're not disputing or changing pathology. What we're actually doing is adding to it. So I'd like to explain to you how MammaPrint was created in the first place and the intention behind it, because it was really pure cancer research that led to something really important in the clinic. And it starts with these two brilliant researchers, cancer researchers from the Netherlands, from Amsterdam, Professor Laura Vanteveer and Professor René Bernards, who have been working at the Netherlands Cancer Institute for many years. And at that Cancer Institute, they had been collecting breast cancer tumor samples for many, many years. In fact, when they began collecting these samples back in the 1970s, this was at a time when the only treatment that was really given for breast cancer was surgery. Women were only treated with surgical removal and no other treatment because the medical treatment hadn't even been developed yet. So they had this collection of tumor samples frozen in their tumor bank, and they also had follow-up of what happened to these women. And it turned out that there was a group of these women whose tumors were in the Cancer Institute tumor bank, a group that did very well without anything but surgery. They had no sign of metastasis within the first 5 years. But then there was also a group that had already had a recurrence within the first 5 years. And so these two researchers asked the question that they could now ask with genomic technology: can genomics predict which of these breast cancers are likely to metastasize in the first 5 years? Because under the microscope, they all looked the same. There was nothing to distinguish the group that was low risk and did not have a metastasis from the group that was high risk and did. So they took these samples and they compared them genomically. They looked at all of the genes that were on or off. And then using computer technology, they came up with 70 genes that could tell these two groups apart from the very beginning, before they'd had any treatment. 70 genes that predicted the risk of recurrence. And that is what became this clinically available test that now anyone can order for someone who's been newly diagnosed with breast cancer. One really interesting and important aspect of this research was that the common information that we get from pathology, namely the receptors like estrogen receptor, progesterone, HER2, and then Ki67, which is a measure of how quickly the cells are dividing, those were not part of the top 70 genes. So this truly added to what we were already getting from pathology. Now, over the years since that first discovery, we've added a great deal of information to what MammaPrint can tell us. The MammaPrint result is reported as a number or an index, either in the positive side, which is low risk, or the negative side, which is high risk. You can see we now split it into 4 different categories, each of which tells us something important about breast cancer: ultra low, low, and then on the high risk side, high 1 or high 2, depending on exactly what the MammaPrint index number is. Now, I mentioned there's a second assay that these same researchers also developed a few years later. And that was to look at the genes that are driving the growth of a breast cancer. And here, of course, we start with those surface receptors that pathology tells us about: estrogen receptor, ER, or progesterone receptor, PR, or HER2, or neither if it's triple negative breast cancer, TNBC. But those receptors, of course, don't tell us how well they're working. The pathology just tells us if they're there or not, but it doesn't tell us how active they are. So then we look at the genes that are turned on or off by these receptors, and that is what makes up the 80 genes in Blueprint that allows us to classify a cancer as luminal or hormonally driven, or HER2 type driven by the HER2 receptor, or basal type, which is what most triple negatives are. So on every sample, even a small tumor sample from a biopsy, we can analyze 150 genes genomically for this gene expression profile. And for the most common type of breast cancer that exists, at least 2/3 of all breast cancers are hormone positive, estrogen receptor positive. We can identify genomically 5 unique subtypes within that one pathology group. And that's really what I want to talk to you about. Because being able to identify these different subtypes allows us to have much more of a personalized approach to treatment. So integrating the genomic information to decision making goes something like this. We, of course, start with the traditional clinical and pathology features like the size of the tumor, the hormone receptor status, the grade, which is another aspect that's looked at under the microscope. And then we combine that with what we learned from the 150 genes from this genomic profiling. And that gives us the fullest picture of how to optimize treatment planning. And treatment planning is not just one decision, it's many decisions. In fact, it's become even more complicated as we've acquired more and more treatments to choose from. So what are the important decisions that we face in someone who's newly diagnosed with an early stage hormone positive HER2 negative breast cancer? Well, of course, we have to take into account different ages, different stages, now even different ethnicities, as I'll mention a bit later. That makes a difference too. And then we put that together to answer the most important questions. Is there a need for chemotherapy or not? And if so, what type of chemotherapy should we give? Because we've got choices. And then if we're going to give chemotherapy, should it be given before surgery or after surgery? Will it make a difference? And then what about the newer treatments that are coming along, like immunotherapy, for example, or new treatments that were just recently approved in the last year, a group of drugs called the CDK4/6 inhibitors. We'll talk about those in a moment. And then what about the hormonal therapy that all hormone positive women are asked to take? The pills that you need to take for 5 years. What's the optimal duration of that treatment? Well, I can tell you happily that genomic information provides answers for every one of these questions. And that's what I'm going to show you. So what kind of answers did the MammaPrint 70 genes and the Blueprint 80 genes provide? Well, let me walk through those with you briefly, and then I'll have time for questions at the end. One very important, perhaps most important answer is that not all women need chemotherapy, and that's what MammaPrint tells us. Many women can avoid chemotherapy, women who would have gotten it or been advised to take chemotherapy if they hadn't had genomic profiling. And here I'm talking about a MammaPrint low risk result. That is this entire group of low risk, both low and ultra low. And nearly all low risk cancers fall into this luminal type, which we would call luminal A as another way of describing them. Now, the way we proved that MammaPrint low risk women do not need chemotherapy was a very large trial, a phase 3 large study that was conducted over a decade ago. It was called MINDACT, but this is the main result. When women who had clinically higher risk breast cancers, larger cancers, or positive lymph nodes, for example, when they were treated with hormone therapy alone and no chemo, they did very well if they were MammaPrint low risk. In fact, when a similar group of women was given chemotherapy, they didn't do any better. We proved with that study that if you are MammaPrint low risk, you can be treated just fine with anti-estrogen therapy alone and without chemotherapy, with an excellent freedom from any recurrence out at 5 years. So we established with this study that MammaPrint low risk indicates women who may avoid chemotherapy, even if they have positive nodes or a larger cancer. And the importance of this is that without genomics, nearly half of the women who would have been advised to get chemotherapy based on clinical factors would have been advised chemo. But we know that half of them are MammaPrint low risk and can safely avoid chemotherapy. But of course, there are women who definitely need chemotherapy because their cancer comes back genomically high risk by MammaPrint. And then the question is, well, should that chemotherapy be given before surgery? How do we decide that? Well, there are some women we can find genomically who should get neoadjuvant chemotherapy or chemotherapy prior to surgery. And that's specifically the group that are MammaPrint high risk in the high risk 2 category. So I'm showing you here high risk, both high 1 and high 2 should be getting chemotherapy. And when we apply Blueprint as well, that could find the tumor that's either basal or luminal. So one way that we measure the sensitivity to chemotherapy is when we give it prior to surgery, we can see how the cancer reacts. And in some situations, the cancer disappears completely by the time of surgery. That's called a pathologic complete response, or PCR is the shorthand for that. So we did a study, we've done several studies actually using neoadjuvant chemotherapy, in which we also classified women by MammaPrint and Blueprint. And recently we did a study where we just looked at MammaPrint high-risk women who got neoadjuvant chemotherapy. And here we showed that the rate at which the cancers completely disappeared, the rate of PCR, was much higher for women with high 2 MammaPrint rather than high 1. Here you can see 6.3% versus 29.2%. We can further separate these groups out when we add the Blueprint on top, and that's shown here. So within the luminal patients by Blueprint, there's both high 1 and high 2, and you can see the difference in their rate of complete disappearance of breast cancer with preoperative chemotherapy. And then if they are basal, nearly all of which are in the high 2 category, the likelihood of disappearance is even higher, over 37%. Now, we can add that to what we already know about low-risk MammaPrint, which is that if you're low-risk MammaPrint, you don't need chemotherapy. And so it's not surprising that if you were to be treated with chemotherapy before surgery, the cancer is not going to respond very much. It's not going to shrink. As you can see here, the rate of shrinkage of disappearance is only 2%, and probably not the best treatment to give. So what we did with this study and others like it was to show that we can genomically predict with MammaPrint and Blueprint whose breast cancers are so sensitive to chemotherapy that they might completely disappear by the time of surgery. That would be this high 2 group, either luminal or basal. So why is it helpful to have the cancer disappear prior to surgery? Well, of course, it allows the surgeon to do less surgery. And in the case of having positive lymph nodes, it might allow the surgeon to avoid having to take out all the nodes under the arm. So it's very valuable to know if you're dealing with a cancer that has this kind of sensitivity. And the implication for managing breast cancer is that we'd like to know this genomic information before surgery, which we could do if your doctor sends the sample on a biopsy rather than waiting till after surgery. Because we know genomically that Blueprint and MammaPrint high 2 predict the highest likelihood of complete remission. Now, I want to talk a little bit more about this high 2 group, because as you saw, those hormone positive high 2 basals had the highest rate of disappearance of their breast cancer. And so these are important to find because we know that some women with hormone positive breast cancers have cancers that are very much like triple negative in the way they behave. And they need to be treated more like a triple negative breast cancer. These are, in fact, the Blueprint basal cancers that one can only be certain to find genomically. So here I'm talking about the high 2 group that come out basal by Blueprint, that are really only identifiable using gene expression profiling like this. So why are these different? Well, they behave so much like triple negative breast cancer that many of us believe they should be treated that way. So one reason we think that is similar to what I showed you earlier, which is the way they respond to neoadjuvant chemotherapy. This is another study we did of over 1,000 women who were treated with neoadjuvant therapy. And we asked, what are the rates of disappearance of their cancers? And when they're defined just by the presence of the estrogen receptor alone, by routine pathology, the overall group has a rate of PCR of 10%. But as I mentioned earlier, when we apply Blueprint and MammaPrint, we can get much better definition and prediction. If it's luminal A, 2%, luminal B, high 1 or high 2, certainly higher, but the highest rate is from these basal breast cancers, very much like true triple negative breast cancers. And so the difference between giving chemotherapy to a hormone positive cancer or to a triple negative cancer is often left to the choice of the medical oncologist, like me. And we would often give a somewhat less strong chemotherapy to hormone positive breast cancers because we didn't think they were as aggressive as triple negative breast cancers. But now we have a handle on that small group of hormone positive cancers that really do need that stronger chemotherapy, these hormone positive basals. It isn't just about how they respond to chemotherapy. It's also about how well women with these cancers do over time. So this is the same study where we followed how these women did out to 5 years after their initial treatment. And so what I'm showing you are the curves for the outcomes for women with high risk MammaPrint breast cancers, either luminal or, more importantly, these basal breast cancers, which are mainly high 2. And what I want to show you is the difference in the red lines between the solid line and the dotted line. The solid line near the top looks very good. These are women who were treated with strong chemotherapy. They had hormone positive basal high 2 breast cancers, and their cancers disappeared. They had the PCR, and they did very well out to 5 years with a low rate of recurrence. But the women in the dotted line are the women who did not achieve a pathologic complete response, who still had breast cancer left in the breast after their neoadjuvant therapy. And that they did less well, unfortunately. They had a higher rate of recurrence, almost a 40% rate by 5 years. So we know that we're able to find this group of aggressive breast cancers that need to be treated with stronger treatment. And the type of stronger treatment we're talking about are choosing stronger chemotherapy or even adding immunotherapy, as we are now doing in a large clinical trial. One other important and surprising aspect of this aggressive type of breast cancer that's hormone positive but acts like triple negative. One other important aspect is when we looked at women of different ethnicities. In this particular study, we did a comparison between Black women with hormone positive breast cancer and white women with hormone positive breast cancer in a very nice collaboration that we had with doctors at Vanderbilt. And what we saw, to our surprise, shown here in the red box, was that this type of breast cancer, high 2 hormone positive basal, was twice as common in Black women as white women. Something that's quite concerning, because we know that in general, unfortunately, Black women with breast cancer have poorer outcomes than white women. And many people think it has many reasons, but we think one possible reason for the poorer outcomes is if this type of breast cancer is not treated with strong enough chemotherapy, if it's undertreated because it wasn't recognized, because these women did not get these genomic tests. So we're hoping that with the application of MammaPrint and Blueprint, these women can be identified, and if they need the stronger treatment, they'll get it. So let me switch in the last few minutes to how genomics can help make decisions about the hormonal therapy. And here I'm going to the opposite end of the spectrum of MammaPrint, the lowest risk end, what we now call ultra low risk, because we found that postmenopausal women who are hormone positive and ultra low may not even need all 5 years of hormonal therapy, which is, as you know, the standard. So here I'm talking about this lowest end in the low risk group, ultra low, and you can see the numbers there for the MammaPrint index. These are all luminal A tumors, of course, but they can't be distinguished just by pathology alone. It's really a genomic profile that finds them. And the reason this is important is because of another old study that we went back and looked at with genomic profiling with MammaPrint. We found a group of women who, as I mentioned, may do well with less than 5 years of hormonal therapy. And the way we found it was to go back to an old trial that was performed in Sweden, the Stockholm tamoxifen trial. And one of these trials was conducted again back in the late 1970s, early 1980s, a long time ago. Only postmenopausal women were enrolled, over 650 of them, and they were asking the question, do women like this need anything other than surgery? Because surgery alone was the standard of care at the time. So they were enrolled in this study and randomly assigned to receive the standard treatment, which was surgery, or half of them were also assigned to get some amount of anti-estrogen therapy in the form of a pill, which at the time was the best thing they had, which was tamoxifen. This was years before the current treatment of aromatase inhibitors like letrozole or arimidex or aromacin. And the women who were treated mostly got only 2 years of tamoxifen. Now, we had access to the tissues from this old trial, and of course, they had over 20 years of follow-up, so they knew what happened to them. And what we learned was that when we tested these cancers many years later, we found that a proportion of them were MammaPrint ultra low. And if they were, they did extraordinarily well. Here, you can see the group that had surgery alone are in the dotted green line, and the group that had some amount of anti-estrogen therapy, mainly 2 years, are in the solid green line. And out to 10 years, both groups had nearly 100% survival without breast cancer. And then in the second 10 years, all the way out to 20, they're still both groups doing extraordinarily well with very little treatment. So genomically, we are able to find this group of women who, if they're ultra low risk and postmenopausal, appear to do well with less than 5 years. And that means that a woman who is ultra low risk could safely discontinue her endocrine therapy before she's finished the standard 5 years. If she's not able to continue because of side effects. Now, I'm a medical oncologist. I believe in the value of anti-estrogen therapy. It not only protects against a recurrence of the original cancer, but we know for certain it also prevents second breast cancers, new breast cancers from developing. So it's certainly best if you can finish the standard 5 years that are advised, but I know very well that many women can't, and they want to stop. And so this information is really useful, because if you are having side effects and you want to consider stopping, knowing that you're ultra low can make it a much more acceptable decision to stop early. Now, on the other end of the spectrum, of course, are those women who need more than 5 years, actually. We know that some women need as many as 10 years of hormonal therapy. And that is still in the low risk range of MammaPrint, but not ultra low. That's shown here, this low risk group who don't need chemotherapy, but they definitely need anti-estrogen therapy, and if they can tolerate it, a full 10 years would be most protective. These are, again, luminal A by Blueprint. So why is this important? Well, we know, unfortunately, that hormone-positive breast cancers are really the main ones that can recur even after 5 years, when we think the other types have been cured, like triple-negative breast cancer, for example. Hormone-positive breast cancers are really the only ones that are capable of these so-called late recurrences. And here's a graph showing you when recurrences occur with different kinds of breast cancer. The estrogen negative are in the red line, where their recurrences are most likely in the first 5 years, and then they taper off. But for hormone positive breast cancers, of those that are going to come back, unfortunately, at least half of them come back after the first 5 years, when for most women, the hormonal pills have stopped. So how do we prevent these late recurrences? Well, the conclusion was maybe we should keep going. Let's extend the hormonal therapy for 10 years, even though we know it carries a lot of side effects. So who really needs those 10 years? That's been the problem. That's been the dilemma. We tried to answer it with a large study. This wasn't an Agendia study. This was a large study conducted by the National Cancer Institute, again, many years ago, asking who really benefits from this extended endocrine therapy out to 10 years. And they enrolled postmenopausal women with hormone-positive breast cancer who finished their first 5 years without any sign of a recurrence. And then they enrolled in this trial and received either another 5 years of anti-estrogen pills, in this case, letrozole or Femara, or nothing, placebo. And then they followed these women out to see how they did. And it turns out that the women who took the extra 5 years of anti-estrogen treatment did do a little bit better. Their disease-free survival, freedom from breast cancer out past 10 years, was 3.3% better than the group that didn't get the treatment. Now, that's not a very big benefit. And unfortunately, this study didn't give us any clinical indications of who really benefited. So, of course, we wanted to know, would genomic profiling help us to identify who really benefits? And it does. MammaPrint can identify within this large group the only ones who really need that extra 5 years. And that's what I'm showing you here. So here's the amount of benefit that the original study found for women who took a full 10 years of anti-estrogen treatment without knowing who really got the benefit. But when we analyzed this group of women with MammaPrint, with gene expression profiling, we were able to separate them into 3 groups. MammaPrint high-risk women who, as you can see here, got no benefit from it. Ultra-low-risk women who had no significant benefit from extended endocrine therapy. And as I just showed you, these ultra-low-risk women may not even need 5 years, let alone 10. But the group that was MammaPrint, low risk but not ultra low, they're the only ones who had a benefit to taking those pills for a full 10 years. And their benefit was big, almost 10% improvement in being free of any recurrence. So we can predict which breast cancer recurrences can be prevented by continuing on for a full 10 years. They made up less than half of the group. So less than half of this overall group who might have been asked to take extra treatment were in the group that really benefited. And over half, because of genomic profiling with MammaPrint, can now be identified as being able to safely avoid the need for extending their endocrine therapy. So lastly, gene expression profiling can be helpful in guiding the use of the newest treatments, like immunotherapy, for example. This is still in the experimental range, but I want to show you the promising data that is encouraging us to think of MammaPrint High 2 as a possible indicator for who may benefit from immunotherapy in the hormone-positive group. So here I'm talking about HIE-2 again, either basal or luminal. Why do we think MammaPrint HIE-2 identifies women who benefit from immune therapy? Well, some of this comes from what we already know about immunotherapy in triple negative breast cancer. As you may know, what immunotherapy does, what it adds is it helps the immune system identify cancers so that it can attack them. Obviously, the immune system without these drugs wasn't able to prevent the cancer from appearing and growing. But when we add these drugs, which are antibodies that in a way uncover the breast cancer so that they can be recognized and killed by the immune system, there's been a very significant benefit in adding these drugs, but particularly for triple negative breast cancer, where it's already in use. But we are now asking the question, well, what about hormone positive breast cancers? Can't we find some group of hormone positive breast cancers that could get an extra boost as well? And so we did get an indication from that from a study called I-SPY, which is looking for new treatments to apply to breast cancer. And what they do is, for hormone positive women who want to enroll in this study, they have to be MammaPrint high risk, either HIE-1 or HIE-2. And what I'm showing you here are 3 different studies that they did where they added immunotherapy to the standard chemo. And then they asked, was there an improvement in the pathologic complete response when you added immunotherapy? And in each of these 3 little trials, it was only the MammaPrint HIE-2 women who got a big benefit from the immunotherapy. In fact, the benefit was an almost doubling or tripling of the rate of disappearance of the breast cancer prior to surgery. So because of that, there's a large clinical trial now underway around the country in the Southwest Oncology Group, or SWOG, which has the number 2206, but it's available all over the country. It's a phase 3 study using immunotherapy and hormone positive breast cancer prior to surgery. And what's unique about it, of course, is that while women who are stage 2 or 3 hormone positive prior to surgery, if they get a biopsy and the biopsy is sent for MammaPrint, if they're high risk too, they can enroll in this study because of what was seen in those previous studies I just showed you. So then they get randomly assigned, almost 1,000 women, to either standard chemotherapy or chemotherapy plus immunotherapy, a different drug here. And then we will see how much it improved. But what we've done is we've used gene expression profiling to identify the women who are most likely to benefit from immunotherapy. Immunotherapy does have side effects, so we don't want to give it to women unless we know for sure it's going to help them. And then after they receive the neoadjuvant therapy, they'll go on to surgery and radiation. So what I've shown you is how MammaPrint and Blueprint genomic information adds important information to standard pathology. So when we define breast cancers as estrogen positive and HER2 negative by standard pathology, we take that group and we split them up into 5 different groups, each of which have their own important implications for treatment. And specifically, some for neoadjuvant chemotherapy, some for extending the endocrine therapy. And the only reason we can do this and provide this information is because we can do it rapidly. We can provide this genomic profiling prior to surgery because by the time we get the sample in our lab, it takes us only about 5 to 7 days to generate a result and send it right back to you and your doctor. Certainly fast enough to answer any questions before surgery. And as we move forward, of course, genomics can be applied to these other types of breast cancer that I didn't have time to talk about. the HER2 positive and the triple negative, something that we'll be looking at in the future. So where's the future going? Well, we really think that genomic information can help identify who will benefit most from these new treatments, as well as old treatments. We've got data already that MammaPrint High-2 identifies which women really need the adriamycin drug, the red drug that carries a lot of side effects but might be necessary for some women. I mentioned about immunotherapy and new signatures that we're developing, but High-2 MammaPrint identifies who may benefit from immunotherapy. And then there's these new drugs that were recently added in, Kisqali or ribociclib, Verzenio or abemaciclib. We actually have data that we're developing that suggests that MammaPrint High-2 patients may be resistant to these drugs and probably should get something else. But that's in the future. And then, as I mentioned, we're applying genomics to these other subtypes, HER2 positive, triple negative. And because of that signal that we saw with hormone positive basal in Black women being more common, we think it's very important to understand better how genetic ancestry may affect breast cancer in this country, where we've got such a genetic mixture of people, African American women, Latin women, Asian women. Genetic ancestry appears to affect the breast cancer that develops in these women. And studying them with these genomic signatures, I think will be really helpful. It already has been. So a way to support the discoveries I've talked about and the discoveries we hope to make is to participate in our so-called FLEX study. This is what FLEX stands for, MammaPrint and Blueprint, full genome data linked with clinical data to evaluate new gene expression profiles. It's very simple, open at over 100 sites around the country. Any woman or man newly diagnosed with breast cancer, stage 1 to 3, who gets a standard MammaPrint and Blueprint, if your hospital signs up to be part of the study, we will take a sample of that cancer at the same time we test for MammaPrint and Blueprint, and we will look at all the genes in the cancer, every single gene that's expressed, and we can ask many questions about it and answer many of those questions. We already have, I'm proud to say, nearly 20,000 women enrolled in this study, and is generating data at every major meeting. So I want to thank you for your attention. I'm sorry I ran so late, but I'll be happy to answer questions if we have time.
Absolutely. That was so informative, so interesting. And we've got a few questions that came in, but I'll encourage attendees to raise your hand or use the chat as we sort of move through. So Dr. Audie, one of the questions that came up, and I was thinking this as well, there are other types of early stage genomic testing. How does MammaPrint and Blueprint differ from other types like Oncotype DX, breast cancer index, and others?
Yeah. Well, so Oncotype DX have data that answers the same question about chemotherapy. Is chemotherapy needed or not? Very much like MammaPrint low risk does. But we have these other answers that we also provide, like what's the likelihood of achieving a pathologic complete response to neoadjuvant chemotherapy? And then with Blueprint, of course, which the other tests you mentioned don't really have, we can identify these subtypes like the hormone positive basal cancer that behaves so differently and really needs to be identified to be treated appropriately. And then the other assay you mentioned, breast cancer index, well, that is used to identify which women may benefit from extending the endocrine therapy out to 10 years. But that's a separate test.
Right.
And it doesn't really answer in the way we do the other questions. Is chemo necessary, et cetera? So I guess I would say the advantage that MammaPrint and Blueprint have is that you get all the answers with this one approach to testing done at the same time. But all these assays have their own data. They're different genes, though. There's really very little, if any, overlap between them. And they don't always agree. So one problem is is if one tries to do both tests.
Okay, wonderful. Thank you for explaining that.
Mm.
We got another question. So Kathleen wants to find out how to get this done. Her surgeon recommended it, but there's a little bit of a wait to see a geneticist, and the plan is for her to start chemo in 2 weeks. So any suggestions for sort of meeting that timeline if a patient is running into a little bit of a time battle?
Well, this is not the kind of test that needs a genetic counselor or a geneticist. That's only for genetic testing of the type that I mentioned earlier, where you're looking for the BRCA gene or other mutations. This type of genomic testing on the tumor is indeed ordered by the surgeon on the sample that made the diagnosis. So it's already present in the pathology lab. And as I mentioned, as soon as that doctor and hospital sends us the sample, we'll give an answer in 5 to 7 days. So you don't have to wait for a genetic counselor or any kind of genetic counselor recommendations. This can be ordered and is commonly ordered by the surgeon or the medical oncologist.
Wonderful. Thank you for that. Great question from Marie. Why isn't genomic testing standard of care in breast cancer patients? I love this question.
Well, it is considered standard of care for the chemotherapy, no chemotherapy question in hormone positive breast cancer. It's limited to that one use. And part of that is because of the way the guidelines that many doctors follow have been constructed, where they were really only focused on that one question, and then relied on pathology and clinical features for all the other decisions that had to be made. So, I'm a medical oncologist. I know very well that oftentimes the science and the research outpaces the guidelines that have to go through committees and a lot of determinations of that sort. But in the minds of many physicians, it absolutely is standard of care for hormone positive, HER2 negative breast cancer patients. And of course, I certainly believe that it is. And the vast majority of payers, as well as Medicare, of course, cover these tests. So it's not considered in any way experimental.
Wonderful. And Kathleen had that question about insurance coverage as well. So,
Yeah.
And if insurance companies don't pay, is there a cost to this, or how would that be determined at that point?
Yeah. So there can be an out-of-pocket cost if the insurance company declines it, although the rate at which they decline is very, very low, because our data are really quite robust and really support the clinical utility of this information. And in fact, insurance companies have gotten the message that if you've got a test that tells you that a lot of women who would have gotten chemo really don't need it, that saves them money. So those that really are on the ball understand that this kind of technology is not only better for patients, but it's better for their bottom line too. So we do have, for those ultimate situations where they won't cover it, a needs assessment program and really a relatively low out of pocket if it ever comes to that.
Okay, wonderful. And they can find that on the MammaPrint website, I presume?
The Agendia website, yeah.
Beautiful. Okay,
Yeah.
perfect. Lee had a great question. So, the topic this evening focused on early stage breast cancer, but is genomic testing useful at all for those with a metastatic diagnosis?
Great question. So the way that genetic or genomic information is being used in the metastatic setting is actually sometimes referred to as genomics, although what they're really looking for are mutations. They're looking for genetic mutations. So technically, that's a type of genetic testing. Because what they're looking for in the metastatic setting is not a pattern of genes like 70 genes in MammaPrint. They're looking for a specific gene that's been that's abnormal so that you can apply a drug to it. So there are many new drugs that target a particular gene if it's mutated in a breast cancer. So that's where genomics and genetics are being used. We are starting to look, of course, at that type of breast cancer in a research setting with gene expression profiling. But for right now, the other labs that are providing this sort of information on DNA and RNA in the metastatic setting are looking for specific genes.
Got it. Great. And then one more question as we round out to 7 p.m. Sharon, great question. Does MammaPrint have a usefulness if you're 1 or more years past surgical therapy and 1 year into endocrine therapy? So in that sort of scenario, what would you say?
Yeah, absolutely. Because we have the additional data that supports endocrine therapy management, we are covered by most insurers for the first 5 years, because we're not only answering the chemo question, we are also answering endocrine management question, which continues onwards. So we've had a number of women who wanted to know if they were ultra low and didn't have a MammaPrint up front, but were having trouble with their endocrine therapy. So that would certainly be an indication. And then as one approaches 5 years, and if a person is tolerating treatment and has some indicators that maybe they're at risk for a late recurrence, knowing whether there's a benefit to extending the endocrine therapy is also a justification for testing beyond the initial diagnosis time.
Wonderful. That's really good to know that you don't have to be really at that early part of the diagnosis and treatment, but up to 5 years, you could gain some good insight to that. So thank you for that.
Right.
Wonderful. Well, that brings us to 7 o'clock. Thank you for all of your amazing questions, Dr. Audie. I second what we are seeing in the chat, in that this was so clearly explained, super informative, and I think really exciting for the breast cancer community to see what we have to look forward to in terms of more specialized decision making and treatment and care. So thank you so much for the work that you do and sharing that with us as well. So this was really wonderful.
Thank you so much for the opportunity to talk to your followers. It's really an honor for me to be able to do that.
Absolutely. All right. Well, a lot. I know I'll be going back to rewatch this segment. So again, this is recorded. It will be in our video library as early as tomorrow. So if you go to uniteforher.org/her library, you can go back to watch the recording. We're also going to share a really useful patient handout that they created to keep track of all of the different diagnoses types, a lot of that medical information as you're connecting with your oncology team. So we'll be sure to attach that with the video library tomorrow. Really useful to keep all of those details clear and handy as you move along. So know that that is coming to you tomorrow. Can we get the recording? So Wendy, yep, that'll be available in our Her library, like I said, as early as tomorrow. Our digital team is so amazing. So with that, I want to thank all of you for joining us again. Again, I want to give a thanks to our education sponsors for supporting all of our segments that we bring to the Unite for Her community. So special thanks to our presenting sponsors, West, Merck, Lilly, and Gilead Sciences. We have additional support from our gold sponsors, Pfizer, GSK, and Daiichi Sankyo, plus additional support from AbbVie, Agendia, and Tercera Therapeutics. So thank you so much. Please be sure to join us for the fun education and interesting education topics we have coming throughout the month of April and ahead. And all of you, thanks for joining us. Stay safe, and we will see you again soon.